Okay. All right. So this is a recording for UW Oshkosh for the doctorate in nursing practice program. This is Dr. Olumuyiwa Adeboye, a physician that I know very well as he helped me complete my doctorate when I went back to school. So he was my mentor, spent a lot of time with him learning about palliative care. So I thought he'd be an excellent person to kind of talk to us about palliative care and its role in the complexity that we all know is medicine. So thank you for doing this. We appreciate it.
Thanks, Luke, for having me. This is a nice opportunity, and it was great working with you. That was like, what, 5-6 years? No, it was when I first started in Wisconsin, so probably 5 years ago.
Yes.
And you were still going back and forth between Stanley and Appleton then.
Absolutely.
Nice.
Back in the day.
Yes, back in the day.
Well,
Congratulations, Professor.
well, thank you. I appreciate that. So tell me a little bit about yourself. What got you into medicine and specifically palliative care?
So I'm originally from Nigeria, and like you, I'm a DK doctor's kid. My dad is a surgeon. He still practices, and my mom is a pharmacist. So I mean, you had two parents in healthcare. I was the first child. It was basically like, yeah, you don't have a choice. You're going to med school. So I ended up in med school in Nigeria. Did that, trained, and then I ended up in Connecticut for my residency program after training in Nigeria. And then I did internal medicine. And it was during that time that I got exposed to palliative care. I had actually thought I was going to be doing oncology. I did an oncology rotation. I heard a little bit about hospice. And then my program director in residency was trained in palliative care and certified. And so she was like, you might be good at this, and kind of like just give me the nudge. So I did some rotations with a few great people. Who was a physician and nurse practitioner. And then it was just like, you know what, you need to do this. You can do this. And that led me down to doing a fellowship in palliative care at Albert Einstein in New York at the Montefiore Medical Center. It was a year. So I did that and then finished that, worked there for a while, and then went back to Connecticut. I worked at the Hospital of Central Connecticut as a palliative care physician. I worked as a hospice medical director with what was called Life Choice Hospice. Did an MBA because I thought, to be a medical director, you need to have some business background. Ended up meeting someone who introduced me to the job I had in Wisconsin where I met you, and worked as a medical director for the palliative care program there for about almost 6 years before I left at the end of May or mid-May. So that's it. I mean, that's been my journey in palliative care so far, almost 10 plus years now.
Great.
Yeah.
Well, good. So explain to everybody, there's always the question, what is palliative care versus hospice?
Right.
So talk to everybody a little bit about palliative care and its goal.
Sure. So when you think of palliative care, the word palliative comes from a Latin word that says palliare, which is to calm, to soothe. So think of it as providing a soothing comfort to people who have a serious illness. Like you and I were talking before this, most of the people who are going to be watching this are nurses who have been in practice already. You probably worked in the ICU setting, worked in the outpatient setting. You've come across patients who are seriously ill. And when you say people are seriously ill, they have an illness that they're not going to recover from. So think of your patients with cancer. Think of your patients with heart failure, congestive heart failure. Think of your patients with COPD. Think of your patients who have end-stage renal disease. Think of all the patients who have dementia, or any chronic debilitating disease that they're not going to recover from. That's what you'd call a serious illness. Also, I mean, working in the ICU setting, you have somebody who comes in with really bad sepsis. They're on like multiple pressors and things like that. That person is seriously ill because you know that their chances of recovery from that are probably going to be very slim. Now, when you think of that scenario, palliative care is considered like a multi-dimensional approach to the care of that patient. It's supposed to provide an extra layer of support, and that support comes in the form of physical, so looking at the symptoms, whatever symptoms those people have with diseases. And when you look at all those diseases we just talked about, they have a multitude of symptoms that are associated with them that are also in common in different, varieties. So think of
Mhm.
pain, the most common one. Think of things like shortness of breath. Think of things like fatigue, nausea, vomiting, insomnia, depression, anxiety. Think of all those multiple symptoms. So, one of the main things palliative care is involved in is assessing for those symptoms in whatever disease you're looking at, and kind of hoping to see how you can help provide relief from those symptoms. Okay. So, there's a symptom aspect, which is the physical part. Then you now think of the psychological part of all of this. How is this affecting the person and their family? Okay, because now
Absolutely.
you're not just working with the patient, you're working with their family. So
Yeah.
that's why this is multidimensional, because you as a provider might not have that skill set, but you have a social worker on your team who's going to help with that. So how is the illness impacting their lives, their families, their work, education if they're in school, their kids, all of those things. You want to kind of
Hmm.
look at that whole approach, because again, you're trying to provide an extra layer of support for this
Yeah.
person and their family going through all of this. So there's that. And the third aspect is now looking at the spiritual aspect. So this is where the chaplain comes in, okay, to kind of help figure out what gives this person's life meaning as they're going through all of this. Do they have a faith background? Are they spiritual? Are they religious? What are the things that they can rely on? Some people tell what, oh my goodness, I have to have the chaplain come see me every time I'm in hospital. I remember one thing I always remember is, we used to have a patient at the cancer center who every time she came in for her chemo, had the chaplain come bless her chemotherapy, that kind of a thing. That was
Sure.
how she was coping with that, you
Sure.
know. So that's that support there. So you have the physical, the psychological, and you have the spiritual aspects. And then it's not about how do you make decisions? Who's making decisions for you? Okay. If you're not
Hmm.
able to make decisions for yourself. And
Yeah.
then it's not identifying who the caregivers are for this sick person and providing support to them as well. So it's multidimensional. So you can imagine that this is something that needs to start early. Okay. So, like, once somebody gets diagnosed, you kind of figure out all of these things and you work with this person as they're going through their treatments. Now, remember, with palliative care, it doesn't mean you have to give up whatever it is you're doing. This is supposed to go alongside whatever
Sure.
treatments. The typical scenario would be a cancer patient who just got diagnosed and they're going through chemotherapy. And so you have all this support going on with them through all of that. And then
Hmm.
you now get to a point in the course of all of this over a certain period of time. We don't know what that time is, it varies for everybody, where we've done everything we can. We're now at a point where it is very certain that death is imminent soon, and no amount of treatment for the underlying disease is going to change that scenario. That is now when you start talking about hospice. The
Yeah.
focus at that time then is more of providing aggressive symptom support to provide comfort to that person at the end of life. So that's hospice. Okay.
Yeah.
A good way to kind of look at this, I tell people, is think of a basket of fruit. I think we've done this basket of fruit analogy before, right?
Yes. Yes.
Think of a basket of fruit. You have all kinds of fruit in that basket. The whole
Hmm.
basket is palliative care. Let's say there's an apple, you take the apple out. The apple is a type of fruit, but not all the fruits in that basket are apples. The apple is hospice. So, hospice is palliative care at the end of life. The whole big umbrella is palliative care, and all of what I talked about, the goal setting, advanced care planning, symptom support, psychological support, spiritual support, all of that is palliative care. And you still provide all of that as much as possible at the end of life.
Yeah. Absolutely. Yeah. There's a lot to unpack there.
Yeah, it is.
It's a
So we can break
very,
it down.
yeah, it's a very comprehensive approach, and I think that's
Yeah.
probably what's unusual to people is how comprehensive it can be. So a lot of
Yes.
times you think about you get admitted to the hospital and you see a cardiologist, the cardiologist gives you their recommendations, and that's kind of it, and you can refer back to the cardiologist. But
Right.
palliative care seems like more of a holistic approach to the patient.
Right. You're taking a look at the whole big picture. Just like you mentioned the issue with the cardio. So you have somebody who comes in with heart issues. They have congestive heart failure. The ejection fraction is somewhere in the 30s, They also have a little bit of COPD. Now their kidneys are kind of tinkling a little bit, so it's a little bit of this, a little bit of that, a little bit of this. But then the main reason they're coming in is maybe the CHF exacerbation. You get the cardiologist saying they fine tune them. Oh, yeah, they're good as new again, but they have a little bit of this, a little bit of this, a little bit of this. What palliative care does then is look at the whole big picture of this person. So maybe this is a 70, 80-year-old person, a little bit of COPD, a little bit of CHF, a little bit of kidney disease. Nobody's looking at the overall big picture. Okay. A little bit of this, a little bit of this, a little bit of that means that that person's quality of life is probably dwindling, and nobody's really talked to them about that. They keep coming in and out of the hospital, bouncing in and out, and nobody's really said, what's important to you with all of what's going on right now? We're not really fixing anything. And that's the thing. There's usually not that kind of communication with people, or maybe if there is, they're not listening. We used to joke that there was that river in Egypt called denial. I don't know if that's appropriate in this scenario, but right. So sometimes there's that as well. So it's kind of helping people say, what, while we're going through all of this, let's be realistic. Yes, you're getting treatment. We're not saying no treatment, but who's making decisions for you if you're not able to make decisions for yourself? What would you want for yourself when you're not able to make decisions for yourself? Would you like to be on a machine, stuck on a machine and not being able to breathe by yourself? Would you want us to jump on your chest and resuscitate you, knowing that the likelihood of getting you back when your heart stops is not? Those are some of the conversations that will be helpful to start having. One of the things I've seen so far, I've learned so far, is the earlier one starts having these conversations, it's like you're planting little seeds. Every little time, just plant that seed. You never know when it's going to take fruit, Unlike when you wait till the end to try and start planting that seed when it's now more difficult, the ground is not fertile ground, it's like hard ground. That's the hard part about all of this. I don't know if I'm making sense.
Absolutely.
Yeah. So that's kind of where the differences lie to a certain extent.
Yeah, I kind of talk about that quality of life, because that's something that I learned from you is so important. Yes. That palliative care really, so much more than any other medical specialty, really focuses on that quality of life with the patient.
Right.
So to you, what are some of the kind of key tenets for focusing on quality of life with the patients?
So that's an interesting thing, because what you'd realize is what's quality of life for me will be different for what's quality of life for you.
Sure.
You could have the same diagnosis and quality of life for everybody is going to be different. So it's going to be finding out what that is for that person. What's important to you? Being able to breathe better. Okay, fine. Being able to be at home. Great. Kind of find out what is important. Being able to spend time with my family. Those are the things you want to ask. So questions like, what's important to you? What do you value the most? What are the things that you hold dear? What are the things that you don't necessarily want to go through if XYZ were to happen to you? So those are kind of things, situations you want to kind of ask people and find out that that's going to be different. Situation we see sometimes, especially when you work in the hospital a lot, is what we as providers will see as a poor quality of life might not be what the patient sees as a poor quality of life. This person will say, what, intubate me, jump on my chest, do everything you can, keep me going, I do not care. And somebody else might be like, what, nah, that's not for me. Just let me go home, spend my time with my family. So it's going to be different for each person. And you never know what that is until you actually sit down and find that out from them.
Great. Yeah. One of the things you talked about too was timeline for when you kind of initiate palliative care. Can you speak to that a little bit for different processes, and when is it appropriate to start thinking about palliative care?
So one of the things that is very common to kind of think about is what's called a surprise question. So you look at a person and you say, would I be surprised if this person were not here in a year? If you can answer, no, I won't be surprised if they're not here in a year, that probably means that person might be eligible for an assessment. They might have unmet palliative care needs. And when you talk of unmet palliative care needs, all the things we talked about, symptoms, refractory symptoms that are not properly managed, caregiver support. Do we have advanced care planning that needs to be done and taken care of? You kind of want to tease out all of those things. So it's going to be different for everybody. But if you have a patient before you that you think, you know what, yeah, this person might not be here in a year, it's good to kind of start thinking about things right there and then. Now, hospice, on the other hand, is more defined. Now, for different disease entities, there are significant things that are appropriate when you think of hospice. So there's in the US, hospice is based on is covered by Medicare. So it's a Medicare service, it's a Medicare benefit, and it's been in place, I think, almost 40 years right now. Started in the early 80s. It's a Medicare benefit and basically requires two physicians to certify that this person has an illness that would most likely cause their death in about 6 months. How do you make that prognosis? Depends on what the disease is you're looking at. So for every disease entity, there are different things. Commonly for heart failure, it's thought that someone who has an ejection fraction around 25% or less, with symptoms and on multiple meds, probably meets eligibility for hospice. For cancer, if you have someone who's got metastatic cancer, who's not doing well and is not going to be treated for their cancer, probably has a prognosis of 3 months and will be eligible for hospice. For COPD, you're on oxygen all the time, you're symptomatic, you can't get from here to there without getting short of breath, probably meeting hospice eligibility criteria, which means your prognosis is probably less than 6 months. You think of dementia, somebody who has dementia, who's bedbound, not eating or drinking, cannot communicate, they're incontinent of urine and all that kind of stuff. That person typically might be having a prognosis less than 6 months. So, different disease entities. Now, sometimes some people don't come to you with one disease entity, it's like multiple.
Sure.
So, in as much as they might not have an ejection fraction of 25%, maybe it's 40%, but they have COPD, they're on dialysis, and they're very symptomatic, they're losing weight. You want to think of the functional status of that person. So, what is that person able to do for themselves, right? If that is changing over time, so 3 months ago, they were walking, talking, moving around, could drive. Over the course of the last 3 months now, they've gone from being able to drive to being wheelchair bound to being bed bound with decreased PO intake, significant weight loss, more than 10% over that time frame. As that scenario is changing, that is how it's going to likely continue to change. And so it's helpful to kind of think about all of those things when you're evaluating patients. I don't know if that helps and makes sense.
Yeah, absolutely.
Yeah.
So, a lot of your practice is inpatient, and a lot of our students are specifically for the family nurse practitioner program. It's a lot of outpatient. So I don't know if you can talk a little bit about the difference between some of those things you do inpatient on admissions,
Right.
and that transition, or what they can expect as far as an outpatient referral.
Right. So typically on the inpatient side, in most places, it's a referral. So you're a consult service, somebody who's seeing the patient says, you know what, this person I'm kind of worried about because of XYZ, and I'm needing help with XYZ. Most times it's because, the person who's the admitting physician is seeing something, and they probably ask themselves that surprise question. I doubt this person is really going to be here, or maybe they've had such a dramatic thing going, and they're like, you know what, this person needs to start having some serious conversation. So that's sometimes how it starts. But remember, on the inpatient side, it's a crisis. The person is coming in because something's happened. And sometimes it's more difficult to kind of start having those conversations on the inpatient side, but it all depends on the severity of what's bringing them in. So it's a referral based service. On the outpatient side, if one were a primary care provider, um, everywhere is different. Um, there are not too many places that have outpatient palliative care programs. So when you think of outpatient palliative care, you can kind of lump it all into the bucket of what's called community-based palliative care. And that could be something like a clinic-based approach where you have a designated clinic where there's a physician who's seeing patients in a clinic. Not many places have that luxury. Or you could have a clinic that's specialized. So there's a palliative care physician in a cancer center, in a heart failure clinic, or something like that. So those are like the clinic-based practices of community-based palliative care. Some places have the luxury of having what you call the home-based palliative care services. So those usually come about from probably like a population-based approach. So some people have a part of an insurance plan. They've been identified as people who are seriously ill, maybe high utilizers or something like that. And now there's a home care service that's been designated to kind of help them with all the things we talked about, symptom approach, a social worker to help them with maybe advanced care planning, all of those things in their house with the goal of finding out what's important and seeing how they can keep them at home if that's their goal, or if they need to go to the hospital, they go to the hospital. Okay. Now, again, this is going to be dependent on what's available in your own environment. In Wisconsin and the Fox Valley, I don't think we had that many outpatient practices that were doing palliative care. The only one that I knew of was ours. I was in the cancer center at St. Elizabeth Hospital. There might be programs that are kind of like clinics. There's some, I think, I'm not sure if in the Milwaukee market, some of the home care agencies had palliative care programs. So remember, I think, okay, when there was ministry healthcare, there was ministry at home, there was what was called the PATH program, palliative approach to treatment at home. So that was based out of home care, and it was more like identifying patients who they felt did not qualify for hospice yet, but could be, managed at home with the help of a nurse practitioner kind of visiting them. There are such programs, but what you find is they vary from place to place, and the
Sure.
kind of service and intensity you get is varied, and all of that is based on reimbursement. Okay. Sometimes the reimbursement is not there unless you're now looking at a situation where you have, again, as part of a health plan, you're providing a capitated approach to care. So it's like, we have 500 members, we're going to pay you $100 per member per month to take care of them at home. That is the model that is being used in some places outside of Wisconsin. I'm not sure we have anywhere in Wisconsin that's doing that now, unless things have changed in the past 3-4 months. But I know in some places in the US, that was what was being done. It's kind of taking that kind of approach for home-based or community-based palliative care. I don't know. Yeah.
So, one of the things you talked about earlier was the physical, the emotional, and the spiritual concerns. Is that generally something, if you do have the option for a palliative care referral, those are the three areas where that palliative care team would focus for your patients?
Ideally, yes.
Okay.
Again, I said ideally.
Yeah.
Because what you find in most places is if you're going to do that, that means you have to have a physician or nurse practitioner or physician assistant to do the physical aspect of things. You need a social worker and you need a chaplain. Okay.
Yeah.
So again, it all depends also on what you're being asked to do when the patient is referred to you. Okay.
Sure.
One of the things you'll find is the practice of palliative care will differ from where you are from place to place. Okay. Now remember, imagine Stanley, compared to Stevens Point, compared to Appleton. Okay.
Mhm.
3 different locations, hospitals of different sizes, right? Resources are going to be different. Okay. So you have
Yeah.
to work with what you have to be able to get that multi-dimensional or multi-modality approach for that person. Now, not necessarily do you have to have that, but you have a small hospital. If you have a case manager who's got some background in social work, maybe they could help with some of that psychosocial stuff. Okay.
Mhm.
Almost all hospitals have a chaplain. Okay. So it might be kind of helping up the skills of some of those people to help them understand what needs to happen with these patients. And then the providers would kind of focus on the symptom assessment, maybe goals and all those kinds of things. But everybody's working as part of a team.
Okay.
Now, I can tell that most of the time what we did with a lot of was goals of care discussion. Okay.
Yeah. Yeah. You always kind of talked about in palliative care, the procedure is the goals of care discussion, the family meeting.
Yes.
So can you talk a little bit about that and kind of your technique and how, cardiology has the cardiac cath.
Right.
Palliative care really focuses on its procedure being that goals of care discussion, the family meeting. So
Right.
yeah, you can kind of
Right.
talk about some of the specifics of that.
Right. So on the inpatient side, we get asked to see. So let's take a scenario. You have 70-ish-year-old patient who's coming with shortness of breath, right? In assessing the shortness of breath, we find out that the ejection fraction is on the lower side, and then unfortunately, there's a lung mass that's being found while they're imaging. Okay. And
Mm-hmm.
now it's a matter of, okay, this person is 70, they already have heart failure of some sort, and we now have a lung mass. And oh, yeah, by the way, it looks like there's a spot in the liver as well. Okay. So let's
Mm-hmm.
just take that as a scenario.
Sure.
So the person who's seeing the patient thinks, you know what, this is somebody who needs to start having some serious conversations about what they want. Okay. And they make a referral to the palliative care team. All right. So the provider goes, meets the patient, introduces themselves, and you have to explain to people what it is you're there for and why you're there. So my typical MO is, my name is Dr. Adeboye. I'm a palliative care physician. I've been asked to meet with you by the doctors taking care of you because they feel some important conversations need to happen. So that's introduction. Well, what is that again? What is palliative care? Well, I'm a physician who works as part of a team, and I'm here to help you what it is you are there for. It might be different for each person. I'm here to help you figure out what's important to you. You know, the doctors feel like things have changed pretty quickly right now, and they think it might be necessary to have some conversations about what's important to you. Does that make sense? Yes?
Yeah.
No? Okay. Is there anybody else that needs to be part of this conversation? You might have had that done already, and maybe everybody is there. So the patient, spouse, children, okay? You might find yourself in that scenario where everybody is there because now they know that this person is here, they're sick, and we might be talking about cancer because, yes, there's a lung lesion and there's something in the liver, okay? So everybody is there. Oh, there's all anxiety in the room and all of that stuff. So yes, the family meeting is now going to happen to kind of talk about what's going on and what needs to happen going forward, right? So typically, the palliative care physician would, or the palliative care provider, if there's a social worker there and they're able to attend, that's good. If there's a chaplain, they're able to attend, fine. You might need to kind of navigate things, monitor things and see what the volume or what the intensity of where you're going into is. Do you think you need that many people in the room at the same time? Or would it be overwhelming? Is it just the patient and maybe just the provider and a social worker would be enough, or the provider and a chaplain would be enough? Or do you have so many people where the more the merrier? You kind of have to figure out all of that. So there's the planning that happens before you go into the room. Once the meeting has been set up, you want to know who's going to be going in, who's going to be speaking, okay? And you have to have done your own pre-planning in terms of looking through the patient's records, figuring out what am I looking at here right now? Because sometimes we talked about this already, the cardiologist just looks at their own aspect of things. So there's the heart issue, which is what brought them in, but now we found a lung mass. So now what's going to happen? We're going to be inviting oncology in, but what would oncology want to do? They want a biopsy, right? To figure out what this is, to determine what the approach is going to be to treat this, right? And then maybe we, in the process of all of this, their kidney function starts going up because we've been diuresing them, and now their creatinine has gone from like 2 to like 6. So you're now bringing nephrology in to start thinking about dialysis or something like that. I'm just throwing a little bit of this in, and you get where we're going with all of this.
Yes.
So the whole point of this is now taking a look at the whole big picture for the patient and whoever is there with them as family to say, you know what have you heard about what's going on? Because what typically happens in these scenarios is you hear a little bit of this from the cardiologist, a little bit of this from the hospitalist, a little bit of this from the nephrologist, a little bit of this from nobody really puts it all together. Oh yeah, but my heart is fine. Oh yeah, but they said my lungs were okay. It's just a little, so you have to bring it all together. And sometimes for some people, they get it at once. For some people, it's going to take some time. The most important thing while you're having this conversation is reading the room as well. If you have a lot of people in there, kind of looking at, okay, what's going on here? Who's talking the most? Who's not talking? But before you start all of that, you want to introduce yourself while you're there. We talked about that. And then have them introduce themselves to you and why they're there and who they are to the patient, if there's a lot of people in there. Then you want to find out what they understand about what the situation is. Tell me what the doctors have told you about what's going on, or what do you understand about what's going on with you currently? So you can kind of get a sense of what they've understood and know where to go from there. Okay? Now, what you find out, unfortunately, is a lot of our colleagues use a lot of language that most patients don't have a good handle of. So you say some things like, oh, we're going to do an endoscopy, and what is an endoscopy? For some people, they don't know what that is. So you have to break it down in terms of that they would understand. We're going to take a look down your throat with a camera to kind of see what's going on in there and probably take a sample instead of a biopsy. So you want to use language that people would understand and would appreciate. So you've tried to get that. So you've gotten that sense of what they know, right? Now, the question is, maybe you've already done the biopsy and you know this is cancer, and then are you now breaking bad news? That's a whole different scenario entirely right now, right? Or is this just a fact-finding mission at this point? Maybe it's like, do you even want to do a biopsy at all? So that's where you now find out, well, knowing what you know right now, what's important to you? How do you think you want to proceed with this? And one of two things. Imagine a scenario where it's just a patient. If it's just a patient, they might say, you know what? Yeah, I think I want to go ahead with the biopsy. Or maybe they say, you know what? I don't want to do a biopsy. Then it's a matter of, do you understand what that would mean? Yes, I do. That means, I'm not going to be here for too long. I just want to go home. And then knowing that this is likely metastatic cancer, and you know that their prognosis is probably going to be a few months, you can talk about hospice at that point in time. Again, you did that based on what the patient wanted. You didn't go in with the agenda of hospice.
Yeah.
Does that make sense?
Yeah, absolutely.
Right.
If I can share a quick story, I don't know if you remember this family, but it was when I was a student with you. You set up this family meeting. Myself, the other nurse practitioner was there. You were there conducting the meeting. The chaplain was there. Social work was there, and it was a large Mexican-American family. And it was in a corner room in St. Elizabeth's on the 3rd floor. There's probably 30 people in this room. This is before COVID.
Wow.
And it was done through an interpreter. And the guy that was interpreting was very expressive, like over.
I think I remember.
You remember this? But,
I
you
think
know, and
that's
it
what it
was
is.
this intense hour and a half long meeting. And it was obvious the interpreter was taking a lot of liberties with what he was interpreting you saying. And, um, you know, it was a very interesting meeting. But the thing I walked away from, you know, watching you kind of conduct this with the family was really, you identified what was important to them, that were speaking on behalf of their father, their husband. You identified the goals, and it helped everybody to really feel comfortable with what was going to happen next and feel like they were involved in the process, not just all kind of all over the place.
Right.
It really helped the family just to kind of focus. You gave them that time to be able to
Right.
kind of express some of the things they were struggling with. So
Right.
I don't know if you remember that specific meeting, but that was
I
a
think it
memorable
rings a bell. I
one.
think
Okay.
it rings a bell. Yeah.
Yeah, I did that multidisciplinary approach. You know, it wasn't like, you know, you put them in contact with the case manager to figure out some things. The chaplain was going to take care of a couple of things. So it kind of became this like understanding of who needed to do what to support the family best.
Right. Right.
So yeah, it was a very powerful meeting.
Thanks for sharing that.
Yeah.
We
The
probably
other,
did
go
probably
ahead.
did a lot of those meetings together, I'm sure.
Well, you walked out of that meeting exhausted, but I walked out. So, yeah, the communication piece was really, really important in that.
And that's, they talk about communication skills, and
Mm-hmm.
there's a need for training for communication skills. You
Yeah,
know, we can say the same thing in different ways, and people take away different meaning. We can say the same thing, but people take a different thing away,
absolutely.
from what we're saying. It's how it's said, the manner it's presented. There has to be some intention behind how you present it. One thing I've always tried, which is hard now with COVID, is you have a patient. You and I are, if anybody watching this right now, we're kind of at the same eye level right now. Imagine
Mhm.
you walk into a room and I'm standing over you. That sensation of having somebody talk over you, it's been found that when the patient is asked, they find that the person who sits down at their level versus the person stands up, even though they're there for the same amount of time, patients feel that the person who sat down spent more time than the person who stood up and was just talking over them,
Sure,
you know?
sure.
And that's why it's always important to kind of meet the patient where they are and try and be at the same eye level. Again, with COVID right now, it's probably more difficult because you're
Sure,
not sure where you're sitting right now and who's
sure.
there and all that kind of stuff. So,
Yeah, can you talk a little bit about, you know, there's a couple of things with outpatient care, specifically to nurse practitioners that maybe need to have a difficult conversation with the patient. You know, number one, the time invested and be able to do that. Number two, there's always, you know, the kind of uncomfortable part of reimbursement, like how do you bill for that?
right.
And then number three, kind of, you know, probably the most important part, how do you communicate that bad news in a setting like an out and, you know, primary care setting?
Right. So as of I think 2016 January, CMMS, Center for Medicare and Medicaid Services, has provided what they call advanced care discussion codes 99497 and 99498. So people can now get reimbursed for actually having those conversations in any setting, outpatient, inpatient. I think it was mainly developed for the outpatient, but you can use it on the inpatient side as
Yeah.
well. So the issue of reimbursement is no longer an issue if you're in an outpatient practice. The bottom line is you have to have the conversation with or without the patient present. You have to spend at least 16 minutes to be able to bill and get paid for that conversation. Okay. The 99497, if you have up to 30 minutes, you bill, but I think they let you do one past the midpoint. If you spend up to 46 minutes, you can bill 99497 and 99498. Okay. Technically, those conversations can be done as part of the annual wellness visit, the Medicare annual wellness visit. So, what are you talking about? The patient comes in for the annual wellness exam. Hey, how are you? How's things? Okay, we've talked about everything else. By the way, have you ever thought about what's important to you and who's going to make decisions for you when you're not able to. Oh, doctor, why do you ask? Well, you have this, you have this, you have this. And I'm a little bit concerned that we really haven't talked about that and we really don't have any plan or idea of what your wishes are. Oh, well, doctor, why are we talking about this now? Well, as your doctor, I think it's important. I'll be doing you a disservice if we didn't have this conversation. And so I just wanted to know, so you have that conversation and you spend at least 16 minutes and you document who was there, what you talked about. You do not have to fill out an advance directive, okay,
Okay.
to be able to bill for it. Okay, but at least you had that conversation and say, you know what, doctor, I hear you. If I'm not able to make decisions for myself, this is who I want making decisions. You document that. And to be honest, if things went really that bad, I don't think I want to be XYZ. I don't want to be intubated. You document all of those things, but maybe you have that conversation and you document it in your electronic medical record or whatever in the patient's chart. You can bill for that.
Okay. So you have a patient with chronic CHF, and you notice that year after year they're having more hospital admissions, more difficulty coping with some of the symptoms. You could include that as part of their yearly physical and
Yep.
get reimbursed for it too.
Yes.
Okay.
Yes.
So, talking about difficult conversations with patients, let's say you have somebody that has been admitted to the hospital multiple times for exacerbations of COPD, exacerbations of CHF. How would you initiate a difficult conversation with a patient? What kind of techniques do you find most useful in kind of talking about some really difficult subject area?
So there's a lot of tools out there, which is one of the things I need to actually mention to kind of help people with these things. So being in Wisconsin, you know about the Palliative Care Network of Wisconsin website, PC Now. They have a lot of
You see
tools
now?
on. Yes, they have a lot of tools for communication skills. Another great place to look for communication skills is an organization called Vital Talk, VITAL Talk. They have videos and resources about, simulation videos about how to kind of have these conversations. But so if you're looking back to your question, if it's on the inpatient scenario, maybe a patient comes out for the fourth time for the same thing and you've been asked to see them. Hi, Mr. XYZ. I see you're coming back. The doctor taking care of you has to come talk to you because they're kind of really worried about where things are at with you. This is your fourth time in the hospital. How have things been with you? Well, you want to get a sense of, again, is find out what they understand about what's going on. Well, it's this heart failure thing. They can't just fix it and I have to keep coming back and all that kind of stuff. And yeah, I know they told me not to drink a lot of water or maybe take less salt and things. And I try to, but I just keep filling up with fluids and all that kind of stuff. I
Mhm.
really don't know what's going on. So you get a sense of what their understanding is, and then it's like, so tell me what do you see about all of this? What's really important to you about this? If they could only fix this thing so I could be at home, and then you break it down in terms of, well, I wish I could tell you we could really fix this, but you know, I worry that we're not going to be able to fix your heart problem right now because this is what's going on. And my concern is since we're not going to be able to fix this, we're going to keep having you coming in and out of the hospital this way. Is that what you want? Oh, really? You can't fix this? There are different techniques, or you kind of use things like there's Vital Talk has a bunch of different scenarios with different tools. There's what they call the nurse tool. So you name the emotion the person is having, you try and understand what's going on, you validate their emotions, all of those things. There's some mnemonics for all the different tools they have on there. I don't remember them off the top of my head right now, but those are good tools that you can have people take a look at. And they have some very nice videos on there. Of course, these conversations can go in different directions. Some people would not want anything, want to hear, and fine. I don't beat people over the head with it. If I get a sense that, you know what, this is where this is going, I back off, let them be, and leave things the way they are. What I
Yeah.
find out sometimes is by the time you have a consistent message from multiple people about the same thing, people start thinking about it over and over again. And they now start realizing, maybe there is some truth to this. But you have the outliers who are going to be like, nope, nope, we're going to go full steam ahead despite the opposite,
Mhm.
So, yeah.
Some of those things you were saying there too, I remember this one from when I was a student with you, specifically using phrases like "I wish,"
Mm-hmm.
we're delivering that bad news, or
Mm-hmm.
"my concern,"
Mm-hmm.
kind of is a way to kind of introduce those topics in a
Empathizing, being empathetic in that kind of,
yeah, excellent.
Yeah.
Okay. One of the questions students had was kind of pediatric palliative care. Are there ages as far as palliative care for different things? Is there any limitation on ages, I guess, is kind
There
of
is
get
the pediatric palliative care specialty. Because I'm an internal medicine physician by background, I'm adult, so 18 and above. So if you do have pediatricians who, if they decide to subspecialize, can do pediatric palliative care.
Yeah.
There's also perinatal palliative care. So you have people who are pregnant, and unfortunately, it's been determined that either one, that child is going to have a disability or would not make it to full term. There's all that perinatal palliative care that can happen in some subspecial. So that's a subspecialization in big tertiary centers. Okay. And of course, there's geriatric palliative care, which is the other extreme. So yes, palliative care spans from in utero to all the way to the end, with family physicians probably are the best suited to kind of do like from the cradle to the grave kind of. So if you're a family physician who's done subspecialty training in palliative care, you can do pediatric palliative care all the way up to geriatric palliative care. But if you're internal medicine like myself, then you're just focused on adults. If you're pediatric, then you can just focus on the kids. The family physician is the person who probably would be able to do all of that whole span.
Yeah. Specific to nurse practitioners, certifications in palliative care?
Yes, there is. So there's the Hospice and Palliative Care Nurses Association. And there is certification for nurse practitioners. And I think it requires you having had, I think you have that, don't you?
No.
Oh, okay. I think it requires, check out the HPNA website. I think it requires
HPNA,
Hospice Palliative Care Network Association, Hospice Palliative Care Nurses Association, HPNA. Okay. There's advanced certification for nurse practitioners, because there's a certification for nurses, but there's advanced certification for nurse practitioners. So it requires a certain number of hours of practice, which usually comes about a year of having worked in palliative care. And then sit for the exam. And then I think it's once you take the exam and you pass the exam, I think you recertify every 5 years or every 10 years. I don't remember the details, but it's on the HPNA website.
Okay.
Yeah. Great. So there is certification for nurse practitioners.
Okay. Yeah. Is that a necessary thing? There's a couple of questions about getting into palliative care. Is that a necessary thing for nurse practitioners to be able to practice in palliative care? Or is it just really good?
If it's a nurse practitioner who's decided this is what I'm going to do, I would say get it.
Okay.
If you know that you're going to be doing palliative care, get that certification. It gives you credibility.
Great.
It gives you credibility, because I can tell you, with the people we worked with, then at least I worked with 5-6 nurse practitioners, and almost all of them had it, because sometimes they were the only ones in the hospital where they were at, and so having that was like, okay, this person really knows what they're doing.
Absolutely. Okay.
So I would say, if you know that you're going to go into palliative care, yes, and that's all you're going to be doing, get it.
Okay. Yeah. Perfect. Couple of things to kind of wrap up.
Sure.
I thought I'd kind of ask you about like specific disease states and some kind of treatments or palliative measures you would suggest to the nurse practitioners, things they can do in the outpatient primary care setting. So big one is heart failure.
Mm-hmm.
I know it's based on symptoms, so kind of
Mm-hmm.
symptoms and some of your favorite treatments for symptoms related to heart failure.
So it depends on what's going on with the person.
Mm-hmm.
The whole issue of symptoms can be a separate lecture. You can do pain as a separate lecture. You can do nausea as a separate lecture. You can
Mm-hmm.
do fatigue as a separate thing. You can do anorexia as a separate, they're all different. So it's basically an assessment. One of the things, though, that I usually find helpful is when you're doing your assessment and you find somebody has multiple symptoms. With palliative care, sometimes you can find one medication that may help with multiple symptoms. So an example is mirtazapine or Remeron. Okay.
Okay.
Remeron is an antidepressant. Starts at dose of 15 milligrams, 30 milligrams. I think you can go as far as 60 milligrams for antidepressant. But it helps with insomnia. It helps with appetite stimulation. So it helps with anorexia. And I think it can help with nausea as well. So in doing your assessment, there's somebody who's depressed or who's anxious, who's not sleeping well, and they're losing weight. You can consider a trial of Remeron starting at a low dose. Now you
Yeah.
have to be aware of the side effects. With any medication you're going to try with anybody, you know what the side effects are. Discuss that with the patient so that when they start experiencing the side effects, it's not going to be new to them. And they won't say, oh, well, that medication, oh my goodness, I'm not going to ever take it again, because that's one of the things that happens,
Sure.
Especially with Remeron. I think some people have this grogginess in the morning, so they take it at night and they just say, you know what, I just couldn't wake up. But if you had told them about that beforehand and they knew what to expect, and it did happen, then they would be more willing to take it and see how that evolves.
Sure.
I'm telling you this from experience now, personal experience.
Sure.
So that's one example. Then, of course, there's the pain management. You can deal with different pain in different ways. You have your non-pharmacological approaches. You have your pharmacological approaches. You can do the multi-modality approach, NSAIDs, Tylenol, opioids. There's a lot of opiophobia right now. People are afraid of opioids. So you only use that if you need to have to use that. You talked about CHF specifically. For patients with CHF who may have shortness of breath that is not relieved by optimizing all their treatment. So they're on diuretics, they're on their ACE inhibitors, they're on everything, but they're still just short of breath.
Yeah.
Let's talk about low dose opioids to kind of help with that breathlessness and help reduce the work of breathing. I said low dose. Okay, so you start low, very low, and see how people respond to that. Okay.
When you're saying low, like, are you using something like
Morphine,
hydrocodone?
morphine 5 milligrams.
Morphine, 5
You could do
milligrams.
2.5 milligrams of morphine.
Okay.
They recommend probably starting like 2.5 milligrams and scheduling it depending on what's going on. Again,
Okay.
you have to be aware of what else is going on with that person in terms of their liver functions and their renal functions to determine what you're going to be using. So that's
Sure.
all part of all of this as well. Again, and then you have to be aware of what other medications they're on and make sure there are not going to be any interactions with any medication you're going to add to what's on their plate already.
Sure.
So this is where having a pharmacist sometimes kind of is helpful to kind of help you walk through all of those things.
Sure.
Right. Another thing that people, of course, always come up with is constipation. So you want to find out what's going on, what's your usual bowel habit, how long has this been going on, what works for them, what doesn't work for them, and kind of figure out what you can do. Some people will tell you, oh, prune juice always works for me. Okay, prune juice, try it. Some people tell them to increase their fluid intake. Maybe that would help. For some people, you might need to start a stool soft. Now you do what you call it, fiber in their diets, so kind of different things like that. Anxiety, big
Mhm.
thing. What are the options that you have? Are you going to use benzo or any of your atypical, Celexa, Lexapro, one of those things? Again, there's different resources that you can kind of have available to kind of figure out what's going on
Mhm.
for the patient. Yeah,
Yeah. And you always kind of look for specific disease states and if there's one medication that could treat multiple symptoms.
that would be more helpful because polypharmacy for some patients might be a lot,
Mm-hmm.
you know. And
Mm-hmm.
then, of course, for your cancer patients, what you'd realize is, of course, it's going to be the effects from their treatments as well. So being aware of that. For some people, it's the metallic taste. Some people, they lose taste in their mouth. Some people, they start getting neuropathy. All of those things. You kind of have to now start figuring out all of those things as things go along.
Mm-hmm.
Yeah.
Yeah, one of the difficult, workups in primary care is always the fatigue. You get these 80, 90-year-old people that come in that are suffering from chronic fatigue. I don't know if you have any recommendations as far as, you know, palliative measures, treatments that can be helpful in those particular situations.
So, you know, you've done all your tests and make sure there's no anemia, right? You want to
So
make
full evaluation.
right, do a full evaluation, check the labs, what are the things that could possibly cause the fatigue. Anemia is a big one. Maybe kidney dysfunction, renal dysfunction might be another one. Okay. You kind of want to make sure you've addressed all of those things and taken care of all of those, and you're still not getting anywhere. Then, are they on any medications that could be causing fatigue? That's another big one, especially in the elderly. Okay, so
Mm-hmm.
you want to kind of look through their medications and see what's on there. Sometimes we talk about, again, it all depends on what the goal is. Okay,
Mm-hmm.
all right. Sometimes people talk about steroids. A trial of steroids could be helpful. If people are on opioids and they're getting fatigue from the opioids, methylphenidate, Ritalin, okay, could be
Okay.
helpful in low doses. Um,
When you're seeing low doses, what's a usual dose that you would consider starting somebody at?
2.5 to 5 milligrams once or twice a day.
Okay.
Yeah. But again, it depends on what the goal is and be careful again, making sure that there's no interactions with any other medications they're on and things like that.
So you're trying to clearly define the goal first before
Yes.
pursuing any of these treatments.
You want to make sure you know what the goal is behind
Mm-hmm.
what you're doing. Because for some people, the fatigue might be just fine. They're like, you know what, I'm okay with this and all that. But if the goal is I need to get up and drive and move around and all that kind of stuff, then obviously, yes. If the goal
Yep.
is, you know what, I'm fine with where I'm at, just leave me be, it's okay. Then you want to make, And then for fatigue, I could be wrong, but I think there's talk about um, sometimes getting people to move around rather than sleep in bed when they're fatigued. Maybe like 30 minutes of some exercise every day actually might help fatigue rather than, getting people to just lay in bed when they're tired. I could be wrong about that, but there's a whole fatigue on its own is a whole topic. It's a whole section on different
Mm-hmm.
things. Yeah.
Yeah. Well, good. Yeah, a couple of those resources, I'll make sure that I get them.
Yeah.
The PC Now and the Vital Talk. Um,
Right.
we'll see about getting a couple of those together for the students.
Sure. There was another one. Was it last year? I worked with a group of people last year and they put out like a palliative care hospice kind of like different topics covering everything we've just talked about. It was a special edition of a journal. Clinics in primary care, I think was a journal.
Clinics
And
in primary care.
yeah, if I find it, I'll send it to you.
Okay.
If I find it, I'll send it to you. And then, yeah.
Okay. Yeah, you gave me a book too. I don't know if you remember this when I was a student that was basically filled with palliative measures for
Okay.
patients, both pharmacological and non-pharmacological.
Which one was that one? I don't remember now.
It was a small notebook size book. I believe
Okay.
it was blue and purple. It was a really good resource. I need to see if I can dig it up.
Okay.
I'm currently in boxes surrounding me in the new house. So.
Yeah. Okay.
Well, thank you so much for doing this.
No
I
problem.
appreciate
No problem. Thanks for having me.
it. Yeah. All right.
All right. Are we done recording?